আল্লাহ এটা দেখতে পাচ্ছি না এই ভাবরা কেমনটা করছে এখন না না খাবো না
কিছু আসতে যাবে ওইদিকে নিয়ে যাও ওইদিক ঘুরে নিয়ে যাও দেখা যাবে না কিছু না না কিছু আসে না কেন বললাম হ্যাঁ
আমরা লাইনে চলে গেলাম স্টার্ট আসসালামু আলাইকুম ওয়া রাহমাতুল্লাহি ওয়া বারাকাতুহু Today 28 January I am from Presidio room or skin we are giving now a live program of workshop on dermatosurgery from the platform of ACSB. What is ACSB? It is a Association for the Cutaneous Surgeons of Bangladesh. We have already conducted more than 8 national and international seminars to uplift our knowledge about dermatosurgery. So we should not go abroad. We should be here to get all this experience and update our knowledge. Today in our procedure room, we have our OT assistants, 2 assistants, our specialists, our doctors, and the cameramans. Now we are going to start this workshop. I don't like to take more time with you. Already more than 50 specialist doctors enrolled their name, and so many from the national and international doctors are with me. Welcome you, sir. You are always welcome. If you have any question, please ask us. We'll be sharing our knowledge with you. We have the experts over here. Who are the experts? Our main Dr. Manas Chatterjee from India. He is a well friend of us. At any time we ask, he is with us. He is a renowned dermatosurgeon and well-known dermatologist. Really, welcome, Dr. Manas. Next, our Professor. He is the president of ACSB, renowned dermatosurgeon of Bangladesh, dermatosurgeon, and vast knowledgeable. He is a faculty member of the dermatology of BCPS. And with us, our good teacher of dermatology, Professor Abdul Wahab. He is the chairman of certificate course of dermatology and professor of Bangabandhu Medical University. Next to that, with us, Dr. Bakhtiar Kamal, who is the founder secretary general of ACSB. And now he is the vice president of ACSB and working in Dhaka Medical College as assistant professor. He also doing so many dermatology surgeries in Bangladesh and pioneer in this subject. And next of us is Dr. Muhammad Tawhidul Islam Imdad. He is from Sylhet, but he is a good dermatologist with doing so many procedures. He is working as a professor of Rajiv Rajaya Medical College. So I will not take time with you. Knowledge and experience we should share with each other. So we have 3 programs today. One is Alopecia areata and nodule 60 acne. We will see the procedure, how the IL and everything is doing. It will be conducted by our Dr. Mahushain, Secretary General of ACSB, and hair transplant surgeon, and vitiligo surgeon, and all other procedures he used to do. Next to it, we'll go on keloid. Who will we conduct? Our expert is Professor Asif Jaman from Green Life Medical College Hospital. He is the Assistant Secretary General of ACSB. And next to it, Dr. Rahmatullah Siddiqui is a member of ACSB. He will see the hypertrophic lichen planus. So let's go and see. And if you have any question, please do ask. We are going to the procedure now. I like to hand over my microphone to our first specialist and dermatosurgeon, Dr. Mahushain.
Okay, thank you, sir. Thank you very much for your well introduction. And I am Dr. Mahbub Shahin. Welcome you all on behalf of ACSB, that is Association of Cutaneous Surgeons of Bangladesh. And it is the first virtual workshop on any dermatosurgical procedures in Bangladesh. So I'd like to welcome all the national and international delegates to our virtual workshop. And today I am going to just show you the steps of the procedure of intralesional therapy in nodulocytic acne first, and then we'll give you the steps of the procedure in alopecia areata. So this is our patient, and as you know, most of the cases of dermatological procedures need local anesthesia. And as you know, there are two types of local anesthesia. One is topical or surface anesthesia. We have already put this anesthesia for these patients of this target area, and then we will go for the procedure. Can you help? Janara, please come on. So first of all, I would like to prepare myself to wearing the gloves, and then Janara, please clean the anesthetic materials from the surface. So first of all, I would like to request, I have to complete first all the steps of the procedure, then we definitely will go for question and answer sessions, and I think it will be very much interactive sessions, and definitely we learn from each other. It is a process of learning, and association of cutaneous surgeons always believe in learning. So I think it will be very good interactive sessions, and definitely our experts will share their experiences, and our young dermatologists definitely get some stimulations, informations, and knowledge that can help their practice in future. So this is a case of nodulocytic acne. Just clean. So we are just cleaning the topical anesthetic materials. Just see the site. Is a classical nodulocytic acne. As you know, nodulocytic acne is a severe form of acne and needs a special treatment modalities, particularly the systemic drugs, especially the systemic retinoids. That is, isotretinoin is the drug of choice. But there are two indications when we can apply intralesional therapy, intralesional steroid in nodulocytic acne. One is if the patient fails to respond the conventional treatments to improve the condition, or if patient wants quick recovery. In these two conditions, we actually advise to go for these IL steroid procedures. So we have already cleaned the field. Now we'll prepare the materials that actually will inject. This is very important. As you know, intralesional steroid concentration is very, very important. So in that case, our choice of concentration is 2.5 milligram per ml. So let's see how will you prepare this 2.5 milligram per ml suspension. This is our insulin syringe, as you know, and the needle is 30 gauge. So, and this syringe is 40 unit syringe for easier calculation. So as you see, there is a 40 unit. So as we use this, prepared the suspension is 2.5 milligram per ml, then we will collect this 2.5 unit of these medicines, triamcinolone acetonide. Just look. We just already taken 2.5 unit of triamcinolone acetonide. Now we will dilate it with the local anesthetics. Give the local anesthetics. Right. We will dilate this with this local anesthetics and make it the solution of 2.5 milligram per ml. This is very important part of our procedure. So look at, already we have prepared this 2.5 ml, 5 milligram per ml of suspension of triamcinolone acetonide. So our target area is the nodular lesion of these patients. So as our target is to reach this drug into the dermis, so we have to push these medicines intradermally. As you know, these intradermal injections, we have to push it at a 15-degree angle with the surface. And look, this is the first nodule. We have to push these medicines at a 15-degree angle. Okay, we are pushing this. And now you have to push how many medicines? This is 0.1 ml. This is 0.1 ml. 0.1 ml of each injection is a parameters that we can push the medicines. Okay. And ideally, if a large nodule, the distance between these two injection is 1 centimeter apart. So we can go for the second lesions. So another 0.1 ml we have pushed. And go for the next lesions. Angulation is very important, but because this medicine, we have to reach these medicines in dermis. So this is another 0.1 ml of medicines we have pushed. So this is how we have to give these intralesional injections in nodulocystic acne. This is another lesions. Go for the 15 degrees, check it and push it with 0.1 ml medicines. As because this is a large lesions, 1 centimeter apart, will give another 0.1 ml of injections. So this is, there is another nodulocystic lesions in this area, preauricular area. We have to go directly into the dermis and go for this 0.1 ml of medicine. This is another lesions. There is another lesions in the air lobule. We have to go for 0.1 ml injection in this particular area. So we have almost completed 1 ml of 2.5 milligram per ml injections of intralesional steroid. So I think this is a very simple procedures, but this is a very, very effective procedures. It is supposed that these injections, these intralesional injections give you quick resolution of the lesions, that is flattening of the lesions within 48 to 72 hours, according to a study from the PubMed. So I think our panel of experts definitely give their expert opinions regarding these issues from their experiences. So this is the basic things. And after completing these intralesional injections, we have to apply some topical antibiotics. Topical antibiotics. So these topical applications of normally We have pushed it in the injection sites. So after putting this topical antibiotic, we have just finished the procedures on the left side. At the same way, we can go in the right side. So it is the same procedures. It's a very simple procedures. As you know, before going to this procedures, cleaning is very important by using some antiseptic preparations. Already we have prepared these patients. So it is also very important. So this is how we actually go for these procedures of intralesional triamcinolone acetonide in nodulocytic acne. Hopefully, there will be a lot of questions and lot of panel opinion experts during our question and answer session. So we have to just complete our first case. Now we would like to go our second case of alopecia areata. Thank you, everybody. Just wait for a few minutes.
Welcome everyone, the dermatologists. Already we have in our online more than 60 dermatologists. Really glad you are with us. So from this procedure, what we learn? Indication is your choice. We just see how the procedure is. There is first line medicine, second line medicine, and when you think it is needed, so you do it. So when you select, you will do the procedure. What precaution you should take? Number one, remember the concentration. Specialist send you the syringe. It should be according to the vial. The vial was 40 milligram per cc, and taken the syringe is 40 milligram unit. This is the one thing. When you're mixing, be cautious about preparing the medicine. Second thing, how much to be pushed in the area, lesion area. What will be the distance? You should be cautious. Procedure, it is your experience. When you go on with the procedure, you know all the things. So work, you will get the experience. Without work, you cannot do the experience. You should go on work. In the year 1994, I went to a workshop and seminar at India, Chennai. At that time, renowned Professor Dr. Shawant, what he told, यार काम करते रहो, experience होते जाएगा. So you should be experienced, you are a knowledgeable person, go on, work and share your experience. And we are also with you. ACSB is with you. We are bringing you here. We'll do another international seminars on October. Our international experts will come and you will show on that day. Today, with the COVID situation, we are doing these things for your, we are all in your platform to know the knowledge, to upload our knowledge, to know the procedure. Now, if you have any question after this procedure, our speaker will give the answer and our panelists will give the answer and their experience. So we are going to our second procedure now. Second procedure is alopecia areata. How IL is given, what concentration and which indication. Please, Dr. Mahbub. Okay, he is preparing himself, so I can speak something other than that. Today we have in our panel list from Dr. Manas Chatterjee from India. He's a renowned dermatosurgeon and dermatologist. And with us, Professor Dr. Shahidullah, President, Dermatology Faculty of BCPS and renowned dermatosurgeon. With us, Dr. Mohammad Abdul Wahab, Chairman of the BCPS, Chairman of the Certificate Course, and he's the Vice President of ACSB. And with us, Dr. S.M. Bakhtiar Kamal, Vice President ACSB. He's the Founder Secretary General of ACSB and Assistant Professor of Dhaka Medical College. And with us, Dr. Muhammad Tawhidul Islam Imdad, Vice President ACSB, Assistant Professor of Rabia Medical College. And I'm also with you to just be knowledge share and experience. I am not a moderator, but doing this thing, if anything wrongs, please forgive me. Oh, I am trying to share my knowledge also here. So when we are practicing in the acne, before there is no Roaccutane, so we are in a dark problem. But nowadays, so many good medicine is there. Select yourself which one is indication and do the procedure accordingly. It is your choice, your decision, your knowledge. You can share with everyone, then we'll be happy. So let's start and go to in case of alopecia areata. So in alopecia areata, you should be cautious during diagnosis. If you're sure it is a alopecia areata, no other things, then do the procedure, and it will be great for you. And if please, I like to ask my dermatosurgeon, keep the documents with you. If you do 10 cases, keep the documents, and it will help us. You have followed this procedure, and you get the knowledge. So knowledge is sharing, and upgrade our knowledge, and we'll rise our dermatology department in a top position in Bangladesh. I think so. It is our proud ACSB with you. So go on. So I like to ask Dr. Mahbub Shahin to go for second procedure.
Okay, thank you, sir. We are in our second procedures, and this is a case of alopecia areata. As you know, this is a very common conditions, dermatological conditions. Alopecia areata, it's an autoimmune disease. So, as you know, patients are actually presented in our chamber with different presentations, maybe single patch, single lesions, sometimes maybe multiple patches, sometimes maybe alopecia total is involving the whole skull, sometimes involving the eyebrows, sometimes the beard areas and other parts of the areas. But most common site of alopecia areata is the skull. This is a case of classical alopecia areata. Would you please show these patients? The classical alopecia areata, only single patches. Please focus this. Please focus. Okay. So just look. This is a single patch of alopecia areata, smooth surface, as you know. And the diagnostic criteria is trichoscopy. As you know, it's a very important findings of diagnosis of alopecia areata. So I think everybody knows about the trichoscopy findings of classical alopecia areata. Is a broken hair, black dots, exclamation point hair, yellow dots, and cordability hair. All these are the features of alopecia areata. But the important thing is the exclamation point here that is clearly seen under trichoscope, which is actually indications of the disease activity. In that case, definitely we have to go for the treatment. And as you know, the first line of treatment is still intralesional therapy in triamcinolone acetonide, particularly over the age of 10 years of old patients. So our patient, he is around, I think, 18 years of old patients, single patches, 3 months history, and patch is slowly but gradually increasing. So according to our treatment protocol, the first line treatment is intralesional steroid. So again, I have to show you the preparation. Just focus this. How can we prepare these intralesional injection solutions for this alopecia areata? As you see before, this is in that case, our preferable concentration is 5 milligram per ml. But there are studies of 2.5 milligram and 10 milligram per ml as well. But most of the experts agreed that 5 milligram per ml is ideal concentration for the management of alopecia areata. So let's see how will you prepare this 5 milligram per ml of intralesional injection suspension. In that case, this is again 40 units syringe, and definitely we'll collect these 5 units. These 5 units of triamcinolone acetonide, and then definitely so definitely this is very important. The concentration is very important for these procedures. If we give more concentration, then definitely it will give a chance of the atrophy of the site of the lesion. So to avoiding the atrophy of the site of lesions or other adverse effects, as you know, there is maybe hypopigmentations or telangiectasia development or chance of infections. So this is very important. So that's why we have to achieve maximum. We have to achieve maximum benefit from the minimum concentration and minimum side effects. So now this is the 5 unit of triamcinolone acetonide injections, and I will make it 5 milligram per ml. Okay, so this is the suspension of 5 milligram per ml triamcinolone acetonide solution, and uh, just now I'd like to already we have cleaned this area by our antiseptic wash, and in that area the ideal parameters of injecting these medicines is intradermally, and 0.1 ml of intradermal injections 1 centimeter apart. So this is the ideal parameters of giving intralesional injections in alopecia areata. So let's start. It's intradermal. You have to check this injections 0.1 ml. Whether it is intradermal or not, how can you understand? This is the swelling. Look at, this is the swelling of injecting site. So 1 centimeter apart, you have to push back, see, and look at the swelling 1 centimeter apart. And this is check and look at the swelling. Close, please close. Close. More close. So look at this. Always check by pushbacking and look at this. There is a swelling. That is medicine is in within the dermis 1 centimeter apart. Always check by pushback and look at the swelling 0.1 ml, and finally this is the swelling. So the ideal parameters are 5 milligram per ml of medicine. We have just finished our intralesional injections in this particular patients, as because the patch is single patch and it's not a very large patch, it's a small patch. So this camera. So this is the procedures we actually treat a case of alopecia areata, particularly the single patch, even sometimes double patch. So ideal indications of intralesional steroid injections in alopecia areata is actually it's called that less than 50% involvement and more than 10 years of age. This is very important. And the concentration of the steroid injection is ideally 5 milligram per ml, but it may be 2.5 milligram, maybe 10 milligram per ml. All 3 studies are available. And each injection, we have to push, that is 0.1 ml of these medicines, and the 2 injection sites, the distance between these 2 injection sites is 1 centimeter. So to following these parameters, we have already completed this procedure, and this is very important. How many procedures we have to give these patients for complete recovery, and when the response of this treatment we can see. So these all are the important issues we have to discuss in our discussion sessions. So that's all about the intralesional procedures of alopecia areata, and I think that will definitely help to our young dermatologists who are very much interested to do these procedures, and these procedures you can do in your office. That's why these are the very simple. If you do it ideally and properly, if you know the details of regarding these procedures, definitely you can do these procedures with confidence. Patient will definitely benefit it, and you can minimize your adverse effects. As you know, steroid has a lot of adverse effects. So thank you, everybody. Thank you very much for your participations, and hopefully all of you will participate the in interesting and important discussions in a discussion sessions. Thank you, everybody. Thank you very much.
Well, I'm again here from the procedure room of oral skin anesthetics. I am Professor Karim. I'm retired professor from Holy Family Medical College Hospital. I'm senior consultant of Holy Family and Oral Skin Center. Welcome you, everybody. So we have more than 60 specialists over here. Really proud. Cheers. And we are here. And with us, the Uniderma, they are assisting the program. They actually brings a good quality of medicine over here. Isotretinoin is also available, and it is available in Bangladesh. And there is an antibiotic cream is Vietnam. They are using it. So this medicine is available, but when writing any medicine, you should be cautious. Mainly when you're writing isotretinoin, it is teratogenic medicine. When you are writing this medicine to any pregnant lady, not to write any childbearing age, with cautious. So let's go and with the session question answer.
Sir, we have some questions.
Yes,
Can
let's start the question answer session right now. The questions are,
okay, thank you. So we have already some questions. That is, which topical anesthetics we should give in nodule cystic acne? Ideally, as you know, the topical anesthetic preparations which is available in our country is lidocaine and pellucrane combinations, as you know, and these are in our market in different trade names. So we use these topical anesthetics, and ideally minimum 45 minutes to 1 hour is needed to achieve minimum anesthetic effects of this drug. So our today's expert, Professor Manoj Chatterjee sir, already share his experience, and definitely I will also agree with him. Sometimes we can definitely do these procedures without any sort of anesthesia, but it depends on patient to patient. As you know, sometimes patients are very much scared about the pain, or sometimes patients are very much sensitive. So in that case, we can definitely use these topical anesthetic preparations to achieve the anesthesia as well as the confidence of the patient. That is very, very important. So definitely our Manoj Chatterjee are definitely he will give his further expert opinions. So another questions.
so I'd like to ask Dr. Manoj Chatterjee to give opinion about this. Dr. Manoj Chatterjee, please.
So actually, no, actually, as Dr. Mahmood has mentioned, that to improve the confidence of the patient, it's always a good idea to, give it. So what it really does is it reduces the pain of the initial insertion, and of course, definitely improves the confidence of the patient. But we need to inform the patient in advance that when we are actually inserting or giving the injection, once we are actually pushing the injection, that time they will get some amount of pain, because a topical anesthetic will not reduce the pain of the pushing of the injection. So that is one thing we can tell the patients in advance. But I agree completely with Dr. Mahbub that yes, definitely it improves the confidence of the patient on the system. And the other thing which I wanted to mention was, regarding when we are treating a nodulocystic acne with intralesional steroid. So what I usually do is I treat the nodules directly with ILS, but when it is a cyst, I normally first drain the cyst. So normally I drain the cyst. Now after draining the cyst, then I flush that area with intralesional with the triamcinolone. So that is what I normally do. So in cysts, I treat it a little differently, draining and thereafter injecting. But in nodules, of course, I do a direct injection. So that is definitely there. And of course, the concentrations have been mentioned very clearly, without a doubt. Just one thing which I wanted to tell the young dermatosurgeons is, remember, suppose you've got multiple nodules all over the face and you are injecting. So now suppose you've taken one syringe, just Dr. Mahbub has shown how to, prepare the dilution. You've finished one syringe, you've injected, you've taken a second syringe, third syringe. Remember, so you have taken now you will come the maximum amount that you can inject in one sitting is 40 milligram per ml. That means you cannot go beyond one vial of your, because one vial contains 1 ml of 40 milligram per ml. So the maximum amount in the entire body you can inject in one sitting is 40 milligram per ml. That means don't go beyond one vial. So you keep diluting, keep injecting, but sometimes what happens is, with young people in the excitement, they has got multiple nodules, he might have some other condition, he might have AKN, he might have something else, and you keep injecting and you do not realize that even post dilution, you have gone beyond one vial. So just keep your injection restricted to one vial. That is very, very important. The second thing is, there was this question about how much is the dose when you're doing on the alopecia areata on the face. The dose does not change. I use 2.5 milligram per ml. Dr. Mahbub has shown you 5 milligram per ml. So you can use anything. But the important thing is, the way to prevent atrophy is, do not go to the subcutaneous tissue. Even if you inject a small amount subcutaneously, you're going to land up in atrophy. So keep in the dermis, always remain intradermal. So if you remain intradermal, you are not going to, and on the scalp, the moment you are intradermal, you will get a pudgy orange kind of an appearance, because especially in the margins where the hair is there, you will get a pudgy orange appearance. When you get a pudgy orange, you are very sure you are in the dermis and not subcutaneous, because the problem of atrophy with intralesional steroids occurs not with that much with concentration. That's why you see publications from 2.5 to 10. So it's not the concentration which is a problem, it is where you are injecting. So if you've gone subcutaneous, that is going to be a problem. Otherwise, the doses, if you're doing eyebrow, you're doing scalp, you're doing face, generally the dosage, of course, I use 2.5 everywhere. But that, of course, as I said, that can vary from operator to operator. Some people use 2.5, some people use 5. But remember, remain dermal and use the same concentration everywhere. So you'll gain experience on a particular single concentration when you're treating alopecia areata. So that is important, because otherwise what's going to happen is you will use multiple concentrations. Sometimes you make a mistake. So best is to gain experience with all alopecia areatas, either on 2.5 or 5. I normally do not suggest the 10 milligrams, but the 5 or the 2.5 one can use interchangeably, and whichever one you are sort of experienced in. I think eyebrow was mentioned and alopecia areata of the face was mentioned. I would suggest the same dosage.
Thank you, Dr. Manas.
Sir, thank you, sir. Thank you very much for your most valuable opinion regarding these procedures. I think we've learned a lot from your experiences. I have a question to Dr. S.M. Bokhtiyar Kamal. You are the pioneer in the field of trichology in Bangladesh. So would you please let us know, though the books are recommended, the first line treatment of alopecia areata of more than 10 years of age patients is intralesional therapy. Do you current practice, or is there any update from your practical point of view? Dr. S.M. Bokhtiyar Kamal.
Actually, thank you, Dr. Mahbub. Actually, I practiced intralesional therapy for almost every alopecia areata patient, except alopecia universalis and totalis. And alopecia areata, you can treat alopecia areata without intralesional steroid, but it is easier to give better result within short time and definitely with intralesional steroids. That's why I usually practice intralesional therapy for alopecia areata almost every patient other than children. Thank you.
Okay, thank you, sir. Thank you very much. Another questions from our audience is that what is the ideal concentration of giving intralesional therapy in the lesions, particularly in the face, like eyebrows, beard areas? In that case, I think 2.5 milligram is ideal dose to treat these conditions like alopecia areata affecting these areas. But one very, very important message from our expert, Professor Manoj Chatterjee, sir, that is atrophy is definitely related not with the dose, but whether we push this drug, whether it is giving it in the subcutaneous tissue or not. Minimum amount of steroid even causes the atrophy. So this is very, very important message from our discussions today, I think, and I think it will help us a lot during our practice, and hopefully we will be very much careful during the procedures we do for alopecia areata or other indications. So I think another important message. So another important message is that injecting intradermally. How will you ensure that is injecting intradermally? This is classic LPUD orange color, what Manoj Chatterjee sir nicely mentioned. So these are the key messages I would like to convey for me as well as for all the audiences. So thank you very much. Thank you everybody for participation, active participations.
I have one
And
question.
so, please.
I have one question to Professor Shahidullah. If the patient develop atrophy after giving injection due to, maybe we may wrong by giving subcutaneously, so what step will be taken? As you have experience, dermatologist over here, in patient develop atrophy after injection, what to do?
Thank you, sir. Before answering these questions, I have to recollect my memory in Singapore in 1992. One patient with alopecia areata was injected by another doctor before me. He was a consultant, and she had atrophy over that area. And I denied to give the injection, and the girl went out of my chamber and was weeping. And she was shown by another registrar. I was a registrar at that time. Registrar, and she took over the case, and she gave transferrin injection again at the concentration of 2.5 milligram. And before leaving the campus, that girl, the patient, lodged a complaint against me. After a few days, director, you must be knowing Professor CLO, he called me and he narrated that he had the opportunity to give injections because the lady was eager to have the injections. But I saw there is some atrophy. But for the patient's convenience, we can give lower concentrations which might not produce any atrophy. And regarding the atrophy already have developed, we should wait for some time and this atrophy will be recovered. And this injection of 2.5 milligram given to that patient is acted as placebo. At the same time also the concentration is also within the range of treating alopecia areata. So it will not do further atrophy, rather it will condition that is atrophy. And one thing what Mahu was saying regarding the injection to the nodulocystic acne, he was emphasizing the intradermal injection. I think it is the intralesional injection. Because when there is a cyst, what Manoj Chatterjee has mentioned, that we must drain the cyst or abscess. We must debulking of the cyst first, then we will flush the surface of the cyst or abscess with transdermal injection. At the same, similarly, if there is nodule, there is no formation of abscess, then we can introduce intralesionally into the nodule. That will cause atrophy of the nodule, which will give us a desired result. But it must be cautious. We must be cautious. We should not be penetrate the needle much below that is the experience that will attain what you have mentioned earlier, that you will do and will do the obtain the experience. Thank you, sir.
We are going on time, so we'll go to the next. Before going to the next, so I like to thanks everybody. Our first one is yes. So now we'll go to the second one. So Doctor, now Dr. Mao will say something to you.
So I think it's a really very interactive sessions and lot of information from our panel of experts, and definitely it will be helpful, and hopefully we can start our procedures from right today. And definitely there are some exciting sessions are coming. My next presentation is with
May I just make one statement? May I make one statement?
Sir, Manoj sir,
please.
Just one point
please.
regarding the atrophy.
Yes, sir.
So if already atrophy has occurred, then the treatment of choice currently is, or previously and currently. So previously we used to inject normal saline. Currently what we are doing is we are doing PRP. So PRP not only is good for the alopecia areata, it also takes care of the atrophy. So using PRP in cases of atrophy following use of intralesional steroid in alopecia areata is a good idea which could be thought of.
Okay. Thank you, sir. Thank you very much for your excellent information. Hopefully all we are benefited from this. So with no delay, I am going to our second session.
Sir, Dr. Tawhidul Islam Imdad wants to say something.
Please, Dr. Tawhidul Islam.
Thank you, Dr. Mahbub Shahin. Already our panel of expert, Dr. Manoj Chatterjee sir mentioned a lot of things. I am adding something to summarize what we'll check during any intralesional injection. First of all, dose, you have already mentioned the dose is, you have to, especially alopecia areata 2.5 or 5. Number two, distance, that is, you have mentioned 1 centimeter. Level of injection, Dr. Manoj Chatterjee nicely told that the not to subcutaneous area. This is a follow. Number of injection in one session. Already Dr. Manoj Chatterjee told that not more than 40 milligram. And another thing is, especially for alopecia areata, is homogenization. That is, when we take 5 milligram steroid injection or 2.5 milligram, after taking this steroid, you will take some air in your syringe, then we'll mix by ups and down for few times, 2 to 3 times. That will be easy for mixing the homogeneous. This is important. Another thing Dr. Manoj Chatterjee already mentioned about PRP. If there is subcutaneous atrophy occurs, in that case, another option is injection of the normal saline of this atrophy area weekly. This is another option. I think Dr. Manoj Chatterjee will know more than me about this. Thank you all.
Thanks, Dr. Tawhid, one of the panel expert. I was supposed to give right now, but you came earlier. So thanks, you summarized all these things. I'm really happy. And we got a new knowledge of giving PRP in the case of atrophy. So we are enriching our knowledge and experience. Thanks, Manoj Chatterjee, and thanks, Dr. Tawhid, for summarizing these things. So I like to go on the next one to Dr. Dr. Shine, Mahbub Shine, please.
So thank you everybody. Thank you very much for this lively active participation. Thank you all the participants, panel of experts. So I am with no delay, I am going to our second session. So hand over to our honorable moderators. Thank you everybody.
Welcome everyone again. We are here. Cheers from Aurora Skin Center. We are in the procedure room. Our next brilliant procedure will be done by our youngest professor, Professor Asif. It is my pleasure and glad to inform you he is my student. I really feel proud when he is here. And he is the youngest professor of dermatology of Bangladesh. So now he is working as a Assistant Secretary of General of ACSB. He will show you in the keloid how we are giving the interlationals. So, Dr. Asif, are you ready now? So he will start. He will give these things, and our panel of experts are with me. So please feel free to give your experience and knowledge with our learned dermatologists who are with us. More than 60 national and international dermatologists are here. My suggestion, please do the procedure to get your experience without seeing only nothing else. You should be, if you are a junior, you should do under some professor or some expert to get a more confidence on yourself. Please, let's start our Professor Asifuzzaman.
Good morning, everyone, and I welcome you all in this live workshop organized by Association of Kidney Surgeons Bangladesh. I am Professor Asifuzzaman, and today I am going to talk a little bit about keloid and would like to show you the procedures of intralesional steroid injections on a lesion of keloid. We have with us a patient, a very friendly and cooperative patient. He himself is a doctor, Dr. Arif Mahmood. He has been suffering from a keloidal lesion. If you can zoom in the camera a bit close, we can see that it's on the central chest. Yes, it is on the central chest. With the direction of the camera, it might look vertical, but actually it's horizontally placed. And he has been suffering from this keloidal lesion for last 10 years, and he cannot recall how it happened. Could be an acne or could be from some kind of an injury. He has been going through these intralesional steroid injections for last 5 sessions on a four-week interval basis. Today we are going to do the same with him. And regarding intralesional injections, there are various drugs that we can use, namely triamcinolone acetonide. There is 5-fluorouracil. Bleomycin is another drug which is also very useful and effective. I did my dissertation in my post-graduation with bleomycin in keloid, and it gave good results. We can combine fluorouracil with steroid. We can combine bleomycin with steroid, and we can also combine intralesional steroid injections with cryotherapy, with laser. There are various laser devices that can be used, and these adjunct therapies or this combination of therapies sometimes are very helpful in treating keloids that sometimes monotherapy fail to treat. However, as today's scope of our demonstration is only intralesional steroid in keloid, I'm going to stick to that. So here we are going to choose triamcinolone acetonide. And regarding the dose or regarding the concentration of steroid of triamcinolone in keloid, it is said that it can vary from 10 milligram per ml to 40 milligram per ml, depending on the site, depending on the position, and depending on the severity of the keloidal lesions. Here we have a chest keloid, which is a chronic one, has been here for a long time, and it has got very it is elevated and it is a farm. So we are going to push 40 milligram per ml concentration here, and I am going to use that which we preferably very commonly known as the insulin series, which is 30G needle, although 27G needle, some books and some research say, is another very good option in delivering the drug, because it penetrates the keloidal lesions very nicely. As we know, sometimes we struggle to put the medicine through the keloidal lesion with a 30G needle. However, we are going to do it with a 30G needle. Thank you. So here my assistant will help me. So here is the, see, it is 1 cc syringe, and it is graded up to 40 for a easier calculation, but we don't need to dilute it. So we are going to take it as a whole. There is a triamcinolone acetonide. So I'm going to take it in my syringe. So I'm going to show it. So yes, the whole of the 1 cc has been. Yes, give me the cap. So now we have already filled in the syringe with the medicine that we are going to inject. This area has been prepared a little bit. We have trimmed the hair overlying the keloid, and it has been the patient has been under surface anesthesia for considerable period of time. Now the thing is that, as Dr. Manush has rightly said, the surface anesthesia we put just to gain some confidence and also to release the patient from the pain of inserting the needle. But once the medicine goes through the lesion, the patient will feel the pain, and we have already discussed that with the patient. Now please, so now we are going to rub the area with anesthetics. So now we are all ready. So we are going to inject, and regarding injecting the medicine steroid in the keloidal lesion, it is very important to look whether we are going underneath the lesion or not. If we go underneath the keloid lesion, what will happen? It will cause the atrophy of the underlying structure, but the keloid will remain the same. And also we have to make sure that the injectables remain within the confinement of the keloid. It doesn't spread in the sideway areas. It will create atrophy and hypopigmentation as well. So there is one angle of the hand that I was told when I was a student in the IOD for my fellowship in laser in Bangkok in 2012, and Dr. Zinda told me that your angle of the hand has to be roughly around 30 degree. That's what he said. So if you can remain in that angle, so that's how we are going. It will very easily go into the lesion, not underneath. So we pull a little bit back, and then we start with the direction of our left thumb, and you can see we are going inside and we are pulling it back, and look at that, the color is changing. See, if you can look at the color, it is blanching and it is getting a bit swelled up. That means we are within the confinement of the lesion. If you look at the color of the area where we have injected to the surrounding, it has got a little bit blanched compared to the surrounding area, which denotes the fact that we have injected triamcinolone in the right area. Now we are going again there. খুব বেশি ব্যথা পাচ্ছেন? He is a very cooperative patient. He says he is not having that much of pain. So again, you can see as we are pushing it, we are pulling our syringe back for the homogeneous spread of the medicine that Dr. Tohidul Imdad was just talking about. So see, we have almost covered this. We have almost covered the upper portion of the lesion. Now we are going there. See, there are some areas which have already got flattened because the patient had already received previous session. So when we are going to push now, we have to, as we are doing it in the subsequent sessions, we have to be very careful that we do not push in these areas. Then we will overdo our treatment over there, and then they will cause atrophy. So we have to take care of that areas as well. So now we are going in that area. We're pulling back. And as we are pushing, you see, see that area has also got blanched. We have almost covered the major portion of the areas that had been elevated till now, and there is a little bit of portion here, little bit of portion there. So I am going to go right behind and I'm going to target this area, and you can see we have covered that area as well. And this is, there is a small pocket that is left here and a little bit of medicine that is left. I think we will be able to cover the area with that as well. We are done with our injection, and we have very homogeneously managed to spread the 1 cc of 40 milligram per ml to the total area of the elevated portions of the keloid, and at the same time we managed to spare this area which has already been treated and already got flattened. Now there are 1 or 2 bleeding spots which would be taken care of, and now we are going to go for some post-procedural maneuvers with the patient. And I would like to tell few things about it, that during the whole procedures, what I mentioned earlier, that the direction of the needle and the way we should pull the needle back as we are injecting is very important. The concentration, it varies from 10 to 40. It depends, as I said, on the site and on the severity of the lesion. We combine therapies, as I said, like for these patients, we can do cryo with intralesional, and there are some other medications that I have already spoken that can also be used in combination with that. Another important thing is pressure therapy or silicone gel sheeting that we sometimes prescribe alongside with corticosteroid therapy. What all these things do, they make the injection easier, they reduces the number of sessions that are required. So this is how mainly keloidal injection is done. So in short, so we are done with this. So now we can talk few things regarding this keloidal injection, and once it is done, I am going to put, see, this topical antibiotic. And
thank you, Dr. Asif.
Patient is happy. Thank you, sir.
Thank you, Dr. Asif. I feel proud that our patient is also a doctor. It is a pleasure how much confidence the patient has, and he came down here. So in our this online session, we have another guest, Dr. Gaurav Das, Assistant Professor, High Tech Hospital from India, Bhubaneswar, India. Welcome, Dr. Gaurav. So we will give you opportunity to speak our experience. So thank you, Asif. If you would like to add anything or any question, I can ask.
If there is any question, then I can talk. And
so I like to ask Dr. Manush to give highlights on injection of keloid. Dr. Manush, please.
So I do it. Hello, am I audible now?
Yes, yes.
Okay, so I do it a little bit differently. Of course, this is absolutely perfect. In fact, this is how we started doing. So I started using 20 milligram per ml. Thereafter, of course, as Dr. Asif mentioned, we use this 1:9 combination, 1 part of triamcinolone and 9 parts of 5-FU. So 1 part of 40 milligram per ml triamcinolone with 9 parts of 5-FU. But what I've started doing now is a little bit different. And what I do now is combined with hyaluronidase. So we use 0.4 ml of 40 milligram per ml injection triamcinolone with 0.6 ml of 5-FU 50 milligram per ml. With we put this 1 ml, that is 0.4 plus 0.6 in 1500 units of hyalase. So the hyalase, what it does is it actually allows these two drugs to penetrate inside hard keloids. If the keloid is initially hard, it becomes very difficult for the drug to actually spread onto the entire keloid. So the addition of the hyaluronidase initially, this really helps. And my experience with using hyaluronidase is first published by Dr. Nilesh Goyal from Mumbai. And the results are actually very, very good. If you are using hyaluronidase, I'm sure those of you who are doing fillers would have hyalase with you definitely in your clinics. So this is a very good sort of combination to use. So I'll repeat that. It's 0.4 ml of 40 milligram per ml triamcinolone plus 0.6 ml of 50 milligram per ml 5-FU in 1500 units of Hyalase. So it becomes a 1 ml with the Hyalase. So this can be injected intralesionally. With this, I actually give a gap of about 4 to 5 weeks, sometimes even up to 6 weeks. So the next injection becomes much easier. After the first injection goes in, the next injection becomes much easier. One thing you need to understand is anytime when 5-FU is there in your combination, avoid going very superficial. Anytime, like using triamcinolone with 5-FU or triamcinolone with 5-FU with Hyalase, anytime 5-FU is there, avoid going very superficial. You land up with an ulceration. That is one thing you need to understand. It's something which doesn't happen much with the triamcinolone alone, but very commonly happens if you're combining with 5-FU. One more tip which I would like to share with you is when you're giving this injection, just keep talking to the patient. The pain is quite severe with this injection, especially in the initial period when the first few injections, because the keloid is really hard, there's no space, and it is very, very painful. So we have seen vasovagal syncopes happen during the procedure and immediately post procedure. So the thing to do is, if you keep talking to the patient, you get an idea whether, because you are concentrating on injecting, so just talk to the patient as you're injecting and keep asking questions and answers, so you know whether any problem is happening to the patient. Of course, post procedure, ask the patient to lie down. Again, in initial period, ask the patient to lie down for a while and then get up, because if the patient immediately gets up, again, the issue with the vasovagal is very common. All of you senior dermatologists have seen this happening, because this is a very painful injection, and post-procedure occurrence of this particular problem is very, very common. The third thing, of course, Dr. Asif very nicely mentioned the fact that please ensure that you all those things that do not go beyond the lesion. But the important thing with keloids is that a lot of times combination therapy works, and it is always good to combine your intralesional therapy with some form of compression. If a combination of these two are used, they usually work much better. And that compression and hydration, actually with a silicone gel or a silicone gel sheet, what it does is basically does a compression along with hydration, and that really helps in these cases. Thank you.
Sir, I have got one experience to share. When I was doing my dissertation, I did it with bleomycin on keloid, and the bleomycin is available at a concentration of 15 international units per vial. So the concentration that is recommended is 1.5 international unit. So I still use bleomycin, and I have seen that bleomycin alone works superior to triamcinolone, and if we combine bleomycin with triamcinolone, then it is sometimes very useful in resistant cases that where alone triamcinolone has failed. And in that case, what I do is that I take it at the same combination that you say, 0.5 or 0.6, 0.4 of bleomycin at a concentration of 1.5 international unit. So we have to dilute it with 10 cc, either normal saline or local anesthetic, to make it that concentration. And then we take 0.4 to 0.5 ml of 40 milligram per ml triamcinolone, and with this combination we inject. Of course, like 5-FU, there is a chance of ulceration with bleomycin, but I have found that the results have been better. So this is one experience that I have regarding treating resistant keloid, especially the keloid that are at the central chest following CABG. So this is my experience, sir. Dr. Manoj sir, if you would like to talk about
so I use a lot of bleomycin, but I use it actually in warts, and very commonly I use it in periungual warts, because a lot of times in periungual warts, sometimes becomes difficult to remove, because some patients don't want the nail to be removed. So bleomycin, my experience is sort of confined to warts where it works well, and the same dose, as you have rightly mentioned, it's 1.5 international units, which is the dose. So what we do is, it's a 15 units. So this 15 units actually we dilute in 10 ml, and then we get that 1.5 units per ml concentration. So that, so you can use actually water for injection or normal saline. You can use either of these two and get that particular concentration.
Thank you, Dr. Asif. I have a question to you as well as Dr. Hassan Bokhtiar Kamal. Do you have any experience regarding the management of this keloid test with triamcinolone acetylcholine along with cryotherapy?
Thank you, Dr. Shaheen Bhai. Yes, I was talking about the combination of therapy right before I started this injection. My experience are there with cryo plus intralesional and also laser plus international. Sometimes when we find that some keloids are so hard that it is very difficult to penetrate with the injections, even if we combine with bleomycin or 5-fluorouracil. In that case, what I have done, I have used laser. So now the recommended laser is pulse dye laser, or Nd:YAG laser has also been recommended. There is another diode of 980 nanometer that can be used. The role of the laser is that it reduces the vascularity so that the keloid gets softened, and then the injection gets the better penetration. I have done it with IPL light. IPL works better. I have done first, I have put the IPL light, then I have gone for the injection, and also cryo. What it does, cryo also, it freezes the keloid, it reduces the size, and what happens basically, it also degrades the collagens. So it makes it even softer so that the penetration of the injectables becomes easier, less number of sessions are required. So these combinations are very good. Either it could be cryo or it could be laser in combination with the injections. This gives better result, even the harder ones, and also it reduces the number of sessions. That's my experience. Thank you.
Thank you, Professor Asif. Same question to Hassan Bokhtiar Kamal. Dr. Hassan Bokhtiar Kamal, please, your experience regarding the management of keloid. Professor Hassan, Dr. Hassan Bokhtiar Kamal, sir, please.
Sorry, he is not in line. So I like to, in our center, we are practicing with IL injection with cryo mainly. And we are making some static, we'll inform you next seminar. So I like to ask Professor Shahidullah, regarding your experience during the combination treatment. So we are using in our center mainly cryo plus triamcinolone. And nicely, Asif shown everything. So I like to share experience of Professor Shahidullah, please.
Thank you, sir. I want to share with Dr. Manas Chatterjee whether he has used verapamil mixed with triamcinolone acetonide.
So verapamil, actually there aren't a lot of publications. There is just 1 or 2 publications of use of verapamil. But verapamil doesn't really work very well. I mean, my experience with verapamil, in fact, from armed forces in India, there was a publication from one of my teachers. But I am not really very impressed with verapamil. And thereafter, in fact, after the initial, 1 or 2 publications, thereafter nobody's really sort of followed up on publishing this, because the results are definitely not as good as using triamcinolone or using 5-FU, as Dr. Asif has mentioned.
I also agree with you. Initially, I used verapamil for a couple of years, but I saw that without verapamil and with verapamil, result is almost same.
Absolutely, absolutely.
Regarding the combination with laser and combination with cryo, I have some experience in this. Yes, of course, it is better penetration is there, and easy to penetrate, and results is very good. And the less sessions are required.
I have a question to Professor Shahidullah, sir.
Yes.
These questions for the physicians from the patient point of view. How many sessions needed to actually control the conditions of keloid, as you know, and what is the maximum regression or maximum cure we can expect from these different modalities of treatment?
Actually, it depends. It actually depends on the clinical condition of the lesion. how hard the lesion is there, how successful is the penetration homogeneously to the lesion, and this will reduce your keloid. And so far I know this ideal is the 6 weeks gap, not 4 weeks, because on 6 weeks gap you will get good result. We can wait for that result and then we can go for the second.
Actually, the duration between these two doses. What is the difference
Yeah,
between 6 weeks difference?
and depending on the hardness of the lesion and depending on the site of the lesion, this number of lesion varies.
What are the number of doses we can see the improvement or response of the lesions?
And a number of doses, that is actually in
How
some cases,
lesions started to improve?
yeah, in some cases not in the central area, the other, say in yellow bules or in the extremities. I have found 3 or 4 lesions is sufficient, but on the chest, central chest, this is very even 15 sessions also required in some cases.
The question to Professor Manoj is, sir, what are the common complications you face to manage your keloid cases?
So, as I said during before that, I think, okay, fine. I'll just discuss the complications first. The most important complication is pain leading to vasovagal attacks. That is, that is a very common thing which happens, especially, in large chest keloids and during the initial 1 or 2 treatments when the keloid is hard. The other thing is infection, the problem of secondary infection inside these keloids. And what I wanted to mention here was that if you are having a keloid in the chest which is not responding, please do an LHR, please get the hair out. And once the hair is removed, that works better, because the problem is the infection actually goes through the channel of the hair follicle. So if you have actually looked after the hair, that really helps, because the infection is a very common problem, because once you have a secondary infection, then you are having a problem giving an intralesional steroid. So you can't treat with intralesional steroid, treat the infection first and thereafter go back. So this becomes a sort of a, ping pong kind of a problem which happens. The third thing, of course, is, hypopigmentation in the surrounding. Dr. Asif very nicely mentioned that if in case you have over injected, or if you have not injected in the right plane, in the right depth and in the right lateral plane, you will land up with hypopigmentation. Atrophy, yes, again, if you've gone too deep, you land up with atrophy. And of course, the problem of over injecting. If you're having large keloids, remember, it is better to dilute, go down to 20 milligram per ml, and then inject, rather than injecting more than, as I mentioned. Ensure that you do not inject more than 1 vial of a 40 milligram per ml at one time in one patient, because you are going to land up with a future development of HP axis suppression if you're doing this repeatedly. So therefore, just ensure that you are injecting the right quantities. More or less, yes, these are the usual complications, out of which, of course, during procedure, vasovagal, and post-procedure development of recurrent, infection is, these are probably the most common. And of course, lack of response, we can call this a complication. A lot of times, lack of response in keloids is probably because of the fact that we haven't, again, injected in the right plane and haven't injected in the right concentration. Below 20 milligram per ml, usually keloids will not respond. So you go either 20 or 40 milligram per ml. And if you are not able to cause a response, it is better to add on other drugs to cause a response in these patients.
Thank you, Dr. Manoj. May I ask one question? Sometimes plastic surgeons are more empathetic to the surgery and follow injection. mainly in the ear lobule side. What is your suggestion regarding this?
So ear lobules, remember, they respond very well to surgery. But one thing, remember, do not touch a surgical procedure on your chest keloids. You are going to burn your fingers. So ear lobule keloids, in fact, it is better to do surgery rather than probably the ILS just to reduce the keloid size to a certain extent before you operate. But the earlobe keloids, definitely including the dumbbell keloids, etc., respond very well to surgery, and surgery is probably a much better option for the earlobe keloids, but never an option for the chest, because on the chest, any kind of surgery would lead to an increase in size of the keloid.
Thank you, Dr. Manoj, for your past experience. May I ask Dr. Gaurav Das, are you in the line, please? Dr. Gaurav Das. Dr. Gaurav Das from Bhubaneswar, India. Are you online, please? I'd like to share some experience with you. Well, so I'd like to ask our panel specialist, Dr. Keloid Islam, to summarize this part of the thing. What we get from this thing. Please summarize this. Dr. Keloid.
Thank you. Already our learned panelist, Dr. Manoj Chatterjee, point out some important point. In my practice, in the first session, before injecting the IL steroid in keloid, I do cryo. It is available in most of the center. Dr. Asif also mentioned that IPL or other laser is also a good option. I usually do, because of the first session there, it is very difficult to inject the intralesional steroid. I chose the first, before giving the intralesional injection, I do the cryo. And then it is very easy to inject this intralesional steroid. In the first session, you can choose the 3cc syringe beside the 1cc syringe, because the first session is very difficult to inject. In that case, you can choose this 3cc session. The second thing important is, first you can do the 40 milligram, but the Dr. Manoj Chatterjee rightly says the next session you will reduce the dose, which will be prevent to atrophy and other side effects. And sometimes when you do very closely inject this intralesional, some there is puncture, there is a very close. In that case, when you push the injection will comes out the another injection site with another puncture. So it will remember to do the proper procedure. That will be effect for, if you do properly, it will be a good result. Thank you.
With us, Dr. Aziz Ahmed Khan from Dhaka Medical. Please, I'd like to share your experience, please. Dr. Aziz Ahmed Khan, please welcome here in this workshop. Please welcome Dr. Aziz Ahmed Khan from Dhaka Medical College. Dr. Aziz Ahmed Khan. Are you online, please?
Yes, sir. Thank you, sir. Thank you, sir.
Thank you. I am listening to you.
Sir, this is a very exclusive operational procedures in dermatosurgery. This is a new arena. We know we know and learn more and more, and it is a very fantastic program. And I think I will learn many things, so many aspects of dermatosurgery regarding this sort of operation. I congratulate all my learned professors, Shoidullah sir and Dr. Mahbub Shaheen to arrange such a program. And we think that we will be very obliged if this sort of program will be arranged more and more by the Association of Cutaneous Surgeons in Bangladesh. That is dermatosurgery. Then we will be learn more. And I congratulate everyone for their everyone regarding to arrange this program for their effortless endeavor. Thank you, sir. Thank you very much, sir.
So ACSB with you always to upgrade your knowledge, to upgrade your experience, to get a work field. So Dr. Mahushan, please.
Okay, thank you, sir. Thank you, Dr. Aziz Bhai. Thank you very much for your participation. So this is the last questions in these sessions. And this question is to Professor Asifuzaman. And the question is from Mehjabin. Do you think, is there any concentration difference of treating keloid considering the age?
Okay, thank you for the question. I'll answer to this question first, then I have two other points to mention. Actually, as I spoke, the concentration varies with the type of the keloid, its hardness, the duration of the lesion, area of the lesion where it is, and also what are the number of sessions that has been done. So these are the things that we consider doesn't vary that much with the age. That is always confined with the lesion itself. That is the answer to that. That is it. So we take care of the lesion and its consistency and also the duration when we try to determine the concentration of the steroid. That is how it is done. And to
Can we get any other addition from our Manoj Chatterjee, sir?
So in children, as I have written, so in children, normally I don't go beyond 20 milligram per ml. So 20 milligram per ml. And in children, I do not, I try and avoid using any cytotoxic drug. So that means I don't use 5-FU or bleomycin in smaller children. I try and avoid that, especially in keloids, because here you need to use recurrently. So 20 milligram per ml is the dose I use, and in any case in small children, you don't get large keloids. You'll usually get a very small lesion, if at all. So it's not really a big problem treating it, but yes, as I said, below 20 milligram per ml, no keloid is going to respond. So I do not go below 20 milligram per ml. In children, normally I stick to about 20 milligram per ml.
Okay, thank you, sir.
Two small things regarding verapamil that Professor Shodla sir was saying. Yes, I have used verapamil in Peyronie's disease. I avoid a steroid in Peyronie's disease because to avoid the atrophy, because you know that verapamil has lesser side effects than triamcinolone. So in case of Peyronie's disease, I have got some results with concentration of verapamil, but for keloid, no. So this is what I had, and with that, I would like to conclude my part or my demonstration regarding the intralesional and in keloid. So now I'd like to ask Professor Afzal Karim sir to.
So we are in the third part now on our procedure. We are successfully conducted first part, second part. Now we are moving towards third part. It will be a pleasure for us if you get something from us and you share your knowledge. Thanks to our panelists, their highlights all the procedures and their experience. Now, next is Dr. Rahmatullah Siddiqui, Senior Consultant of Oral Skin Anesthetic. Highly knowledgeable, and he's doing so many things. And now today he will see the hypertrophic lichen planus, how you give this IL injection. So now Dr. Rahmatullah Siddiqui is a renowned dermatologist and highly knowledgeable person and dedicated to dermatosurgery also. So now we are proceeding towards Dr. Rahmatullah, please.
Thank you. Professor Afzal sir, for give me a chance to participate with these demonstrations, and very much thankful to ACSB and my dearest colleague Dr. Mahbubur Rahman Shaheen and all other participants and experts here. Assalamu alaikum. I am Dr. Rahmatullah Siddiqui, consultant oral skin and aesthetics. You know, today this is third sessions. I think all at this time we are very much familiar with intralesional therapy. First of all, alopecia areata by Dr. Mahbub Shaheen, and later on by our renowned Professor Asifuzaman for keloid. So now one very embracing disease, I want to say, because you know, lichen planus, it's alter immunity with very much painful and distressing for patients as well as a physician also, with very chronic conditions with characterized by the papule and plaques and the severely itching disease. Most of the time we're facing in our clinical practice. So when there's so many classification of lichen planus, we focus on today's for intralesional therapy, especially hypertrophic lichen planus. though generalized lichen planus or classic lichen planus or other forms you know better than me. Especially we choose hypertrophic lichen planus for intralesional therapy. So little bit sharing of my experience today with you. I think my experts are here. I also gather knowledge from their experience. So first of all, in intralesional therapy, before any procedure, we have to do two sessions. And now we are go for demonstration, but before the two sessions, one is counseling with the patients. What's going on here? Because intralesional therapy, we are very much familiar with this procedure, but my patients who is this first time for his life or her life. So I think before this procedure, we have to consult with the patients what's going on here. So this is a discussion about the disease and the procedure with the patients. Later on, the intralesional therapy, little bit painful. So we go for topical anesthesia for little bit benefit for the patients. So all these two things are finished. Now we go for the antiseptic wash. So my dear learned audience and my dear honorable experts here. So we go for now. You see, hypertrophic lichen planus have a special definition, and this is a lower extremity. They all the time says a very common site of here. You see here, this is a large plaque with a satellite lesion also, and with hyperpigmentation as well as hyperpigmentations involved in the anterior lower leg. So we go for the intralesional therapy. In intralesional therapy, we choose triamcinolone acetonide because this is the depot preparation is take to release in skin for a long time. For the sessions, we choose this steroid, local steroid for intralesional therapy. Okay, this is the disease of altered immunity. So according to books are very, so many reference, we choose here for 10 milligram per ml. Before last sessions, Dr. Asifuzzaman very nicely mentioned that we choose the concentration of the triamcinolone acetonide according to four things. One is what is the disease condition. Another thing is what is the thickness of the lesion. Another condition is the where the site of involvement. Another one thing I want to add, the last previous response to the treatment. So these things are very important to consideration the dose of the triamcinolone acetonide in case of any intralesional therapy. So আপনি এটা ছোট্ট একটা ওষুধ আমরা এখানে দিব, হ্যাঁ, আপনি ব্যথা পাবেন না কোনো, হ্যাঁ, ঠিক আছে? ওকে। So this is actually intradermal lesion, better than me. We are pushing. আমরা খুব হালকা করে দিব, ব্যথা পাবে না ম্যাডাম, খুব হালকা করে দিব। পেশেন্টকে বলো। হ্যাঁ। লাগবে না, অল্প করে ম্যাডাম, অল্প করে দিচ্ছি, আপনি ব্যথা পাবেন না। একজন ভালো ভালো পেশেন্ট আছে। হ্যাঁ, লোকাল দাও আছে না? হ্যাঁ, এই আস্তে করে দিচ্ছি আমরা। My dear learned audience, you see, we are pushing. Okay. আচ্ছা। Okay. এই পেশেন্ট চুজ করছে দিবেন। So, my dear learned audience, patient is a little bit fear. We discuss with the patients, but I think this is a more panic patients. Little bit, you see there. Acha. Okay. So see, we around the lesions, we try to concentrate our medications, my dear learned audience. Okay, fine. Okay, my dear learned audience, the patient's a little bit fear for intralesional therapy. We complete all the procedure. First of all, we discuss with the procedure about with the patients, and later on, we go for topical anesthesia for a little bit lessen the discomfort of the patients. But still, patients is fear for intralesional therapy. Sometimes it's happened due to patient personality. Don't worry, we.
So, welcome everyone. We are in the third part of the session. It is a hypertrophic lichen planus. You should know the indication for IL therapy. So it is your choice, your decision, when you will be on medicine, when you will be on topical, and when you will be on procedure. It is your choice, but be safety. Look, this patient has some sensitive, so she's sensitive to pain. So remember, you should be cautious. And there is a, Dr. Manas clearly indicate you, the chance of vasovagal. Please don't take it as fun. When you are doing procedure, you should be cautious. In a 100,000 patient, one patient may go to shock. So be cautious and be prepared for this thing always. It may happen. So there is a one contradiction. There is a problem of shock due to vasovagal. So be careful. Number one. So what we got today from today's time. So for the case of atrophy, you should not be afraid. There is some remedy also there. Dr. Manush clearly said you can do some PRP and it will give a good result. So we don't expect the atrophy, but if happens, not to worry. So the experience and share the knowledge is the best thing. Now, again, we are going for another case. So now Dr. Ramatullah will do the second procedure. Okay, please.
Welcome back, my dear learned audience. You know this actually this in case of hypertrophic lichen planus, you know this better than me. It's a little bit a dangerous complication waiting for the patients if we are not rightly manage our cases. You know, in hypertrophic lichen planus, there is a chance of complications like squamous cell carcinoma. And we have some papers about this, and also in some study also shows this. Hypertrophic lichen planus there is a chance of transform after few years. There is a complication like squamous cell carcinoma. So it's a very important to us, and we practice also. My dear learned audience also know that we are widely managed the hypertrophic lichen planus with intralesional therapy as well as to some systemic medication also. Our learned say if there is a chance of fear for complication, we can go for systemic retinoid like acitretin to manage our cases. So now we go for another cases. Luckily, we manage one case for hypertrophic scar. I think so this will well known. In the previous session, Dr. Professor Asifujaman very nicely demonstrate the cases. So just a little bit with our sensation, we go this for this. So we wash it, okay, and then we go for our okay. Now you see, my dear learned audience, you see these cases, and we go for the another cases for intralesional therapy. There is we mix here 10 milligram per ml, and we go for the demonstrations. Okay, little bit painful, but if you talking with the patients, this will be helpful for the patients. Sorry, ma'am. Right. Okay. Then we go for another. If we assure our patients, patient will be a little bit compliance to us. Sorry. My dear learned audience, have any question? We are very much happy to answer you if related question have. Okay. I think so this is not so thick lesion, so we not go more amount, not concentrations. Okay, I think so. So this is our procedure. After procedure, to have some antibiotic cream. Also, we apply in the lesional area. This is for prophylaxis for any bacterial infection or other than this. So, my dear learned audience, this is our presentations in intralesional therapy. So many things we are demonstrated here with our learned experts. And if any question, we can go for conversations. Thank you. Give me a chance to participate in this demonstration. Thank you.
So we have completed our procedures. Now we are going into the question and answer sessions. So now they start the question and answer. So many questions we are got from Mabu, please.
And my first question is to our learned expert, Professor Manoj Chatterjee, sir. Do you please let us know what is the basic difference between keloid and hypertrophic scar to manage with intralesional therapy? Sir, please. Regarding the response and outcome, prognosis. Sir, please.
So remember the key, the hypertrophic scar will not grow beyond the limits of the original wound or the original disease which caused the scar. So therefore, because the hypertrophic scar will not grow, so the number of sittings required are usually very less. Usually in 1 or 2 sittings, one can treat a hypertrophic scar and it will not recur. In a keloid, that's one thing which I wanted to mention. Sometimes in chest keloids, you might need to treat them with maintenance treatment. That means you've treated the keloid is resolved. After some time, the keloid will again come up and you might require maintenance treatment. This does not happen with a hypertrophic scar. So once you have treated a hypertrophic scar, the hypertrophic scar is done and dusted. And therefore, because this lesion will not keep growing, and that is why it's much easier to treat a hypertrophic scar as compared to a keloid. So that is the important point of difference as far as the hypertrophic scar. Of course, we know the biology. I don't want to go into the biology, but as far as the therapy is concerned, the prognosis for surgical therapy is much better. They do not require maintenance, and usually much lesser number of treatment sessions are required to treat these cases. What was the other question that you had asked?
What are the prognosis comparing this?
So prognosis, of course, as I said, the hypertrophic scar, the prognosis for a complete regression is much better. In fact, if you treat them with intralesional triamcinolone, they usually will respond well. A lot of times, these hypertrophic scars actually resolve even spontaneously. So sometimes a lot of a keloid will never respond spontaneously. It will continue to grow, whereas a hypertrophic scar, after a certain period of time, between 3 and 6 months, after that period, during which time it has grown, after that period, it might actually resolve on their own. So we actually do not address hypertrophic scars at the initial period. We counsel the patients and tell them wait for it to resolve on its own. If it resolves on its own, that is fine. If it does not resolve on its own, like compression therapy and simple modalities of treatment work very well for hypertrophic scars. Even just using topical corticosteroid, just tell them to really rub the topical corticosteroid on the lesion. These lesions work very well. So the overall prognosis is definitely much better for hypertrophic scars as compared to keloids. Topical corticosteroids have got nothing to do with, no response will happen as far as keloids are concerned.
Okay, sir. Thank you, sir. Thank you very much for your valuable opinion regarding this. So my next question is to our Professor Shoidullah, sir. Would you please let us know what is the best treatment option for hypertrophic lichen planus patients from your experience point of view? Professor Shoidullah, sir.
Thank you, Shamin. Can you hear me?
Yes, sir. Yes, sir. You can hear, please.
For hypertrophic lichen planus, one of the best option is intralesional steroids, no doubt in it. But before that, we can use potent topical corticosteroid. If it fails, then we go for intralesional steroid. Regarding selection of the cases, I have a question to Dr. Rahmatullah. Why discoloration over each of the lesion of this hypertrophic lichen planus? Why you selected this case for demonstration, Dr. Rahmatullah?
Actually, sir, can you hear me? Sir.
Relation with leukoderma. Why you have selected this one?
I can answer these questions because this is our old patients. And as you know, getting patients are not so easy for the private centers for this workshop. So this is our old patients, and this patient is already have 4 to 5 doses of intralesional therapy, and definitely we have already discussed the adverse effects of IL therapies, IL steroids, and that's why it develops some sort of depigmentations due to steroid therapy.
Oh, that is a steroid induced.
Yes, sir. Yes, sir.
Actually, in hypertrophic lichen planus, you see the depigmentation which happens is actually a destruction of melanocytes, a physical destruction of melanocytes which happens in a lot of these cases because of continuously rubbing these areas and scratching these areas. So that sometimes leads to a physical destruction of melanocytes. It's something which you see in lichen simplex chronicus also. If you see old long-term lichen simplex chronicus, or even papular amyloidosis, papular lichen amyloidosis, because of repeatedly scratching, they will develop depigmentation. So the depigmentation can occur in these cases even because of the physical work of scratching, which causes actually the melanocyte destruction and the melanocytoragy which happens.
Yes, so thank you, Dr. Manoj Chatterjee. This is one explanation of that high depigmentation, because only steroid-induced depigmentation is not the only factor here, because repeated friction and the disease itself may destroy the melanocytes, which may cause leukoderma. Second, hypertrophy, that is hypertrophic scar. Dr. Ramatullah, you have selected this case. I think this linear type of hypertrophic scar, if you infiltrate, what will be the outcome? It is likely that there will be a hypopigmented or wrinkled patch flat with the surface, but the diameter of this lesion will be the same. So in that case, can we go for cosmetic repair of the large two ones? The small ones, I have no question. The large two ones, can we go for cosmetic surgery? Reduce it because these are smooth linear hypertrophic scars. So we can go for 2 linear incisions again and remove the hypertrophic scars, and we can go for intradermal stitches. Can we get better results?
This is a very good option also. You mentioned this very good option also to manage such cases. By my concern is that if there is in hypertrophic lichen planus, there is some area of hypopigmentation, what sir mentioned very rightly. If this is not due to steroid hypopigmentation, this is due to disease process hypopigmentation.
Sir, I can just interrupt Dr. Rahmatullah. The first question is from you that can we go for the scar revision surgery in case of hypertrophic scar patients? So it is a big debate. I think these scars are very narrow. So whether it is a very good choice of going scar revision surgery or intralesional therapy of steroid or cryotherapy, as you know, these are the very good treatment options. So I think it's a big debate whether the scar revision surgery is a better option in that particular cases. But I can give you the information regarding the patients of hypertrophic lichen planus. She is my old patient. As we know, most of the hypertrophic lichen planus are presented with hyperpigmentation, not hypopigmentation from my experience, most of the patients, definitely there is a chance of hypopigmentation in case of hypertrophic lichen planus. Commonly also we found, but in this case, patient actually presented with some sort of hyperpigmented pigmentation on the lesions. And after giving the intralesional injections, these patients develop some sort of depigmentation, particularly in this case. But definitely, I fully agree with all of you that definitely there is a chance of hypopigmentation or depigmentation due to the disease process. But at the same time, hyperpigmentation is also can occur due to the disease process. Thank you, sir.
Thank you.
Actually, just one small little comment with this particular patient. I think this patient has got multiple, these hypertrophic scars. Probably these are all result of hesitation cuts. I think they are on the forearm. Are they on the forearm? So they
yes,
appear. So they appear to be hesitation cuts.
Yes, sir. Yes.
There are so many in number. Because of the multiplicity, probably a surgical option. This particular case, maybe if it was one or two, we can do a surgical option. But if there are too many, I would agree with the doctors that yes, probably in this case, the ILS might be a little better than going for surgery because there are so many of them. So doing so many surgeries may not be very good, and ILS actually smaller numbers of sessions will lead to a regression. But yes, this might lead. You see, these are actually the scars, as I said, they are probably hesitation cuts. So yes, definitely a bit of depigmentation might remain. And if the depigmentation remains, then again, just like in stria, here also there is a role for doing a bit of PRP. Here also PRP is a good idea.
Yes.
Just to leave, just the depigmented linear marks of hesitation cuts. Again, PRP works well in some of these cases. That really helps to improve the pigmentation also.
Thank you very much. We are on time. ACSB loves on time. We always start and finish on time. We are on the last stage of this program. Now I like to ask our learned professor, M.A. Wahab, as the chairman, as the vice president of ACSB, he will give some highlights of this today's program about the suggestion or anything regarding this workshop. Professor Dr. Muhammad Abdul Wahab, Vice President ACSB, and he is also the chairman of our DOC course. Please, Professor Wahab, highlight about today's workshop. Professor Wahab, are you online, please? So I'd like to ask Dr. Bakhtiar Kamal to give highlights about this today's seminar, today's workshop, please. Professor Bakhtiar Kamal.
Okay, sir. Thank you, sir. This was very lively workshop. I think this workshop helps a lot of all of us, both youngster and older. This is a very fruitful workshop. I hope everybody can perform this type of procedure from today onwards. Thank you all.
Now I like to ask our president ACSB okay, fine. So I like to ask our panel of experts to give their something say about this seminar. First, I will ask Dr. Manish Chatterjee, please. Some highlights.
No, this is I think really wonderful for young dermatologists and dermatosurgeons. When you are seeing a demonstration and in the current scenario is probably the best thing that can be done. And intralesional therapy is, it is easy to do, and it is can be done in the clinic very easily. Does not require a lot of equipment, and it can treat a large number of conditions which cannot be treated with medical therapy. Because of this reason, it improves and increases the scope of what the dermatologist is able to do. And therefore, all of us as dermatologists must know the various modalities of intralesional therapy so that we can treat conditions. For example, nodulocystic acne. Once you have got large nodules, you can treat with any medicine. It's not going to work. So it's always best to know that in these cases, yes, intralesional therapy works. One more thing about intralesional therapy in acne, nodular and nodulocystic acne. You can inject intralesionally clindamycin. Remember that. So clindamycin, one more tip for all of you, just the standard injection clindamycin which you have, you can inject 150 milligram per ml intralesionally in nodulocystic acne, especially cystic acne. It works quite well. Thank you very much.
Our participant, Dr. Gaurav Das. Are you with us? Dr. Gaurav Das? You are from Bhubaneswar, India. I have tried to line up, but I don't know. It's our misfortune. Okay, fine. So I'm going to the next. So it is my duty now to wind up. It's a very bad job, but I should do it. First of all, I like to thank our speakers. They are really brilliant. And they are done it properly. I don't know. If anything happens wrong, it is our fault. But it is successful. That is, you are with us. That's why. You are 60 and more than international. So I am really grateful to you to make our program successful. So thanks to you and thanks Professor Dr. Manoj. He's always with us. Really, Dr. Manoj, you are great. And you are with our family members. And next time when you will be October, we are welcome to participate here at Dhaka. And now I like to ask Dr. Wahab, Professor Wahab, he's online now. He will say something about our workshop. Please, Professor Wahab.
Thank you, Afzal sir. Though I was not present all the through time because of my commitment, that is taking exam and other things. So thanks first of all, thanks the presenter, Dr. Mahbub Shahin Rahmatullah and the Professor Asif for their brilliant presentation. And also thanks the panel of experts starting from Manoj Chatterjee from India, Professor Shoidullah, and others. And also thanks all the participants participating in this workshop. I think this is the first time virtual workshop on dermatological, that is the workshop on dermatosurgery. So I think all of we are benefited and we have learned and heard many things about the procedure, but some of the procedure probably we knew earlier, but correction of the procedure, that is the method and the topical application, anesthetics, and dose of the injectable, that is IL, triamcinolone, and also the other adjuvant. We have learned many things from, especially personally, thanks all of them who arranged this workshop, and I hope this type of workshop should be arranged at a particular interval so that we will be benefited in the new arena and the fresh of the old arena of the field of dermatosurgery. So I thanks all of the participants and all of the presenters. Thank you, Dr. Professor Afzal Bhai. Assalamu alaikum.
Thank you, Professor Wahab. Now I like to thanks our cameramen who are working hard, our OT staff, those who work hard, and the presenters. As a whole, I thanks you all. If any problem or any mishap happens, that is my fault. I might excuse to you. Now, what I got from this today's seminar, number one, myself, what I got. Number one, if there is atrophy or complication for atrophy, you should go for PRP. This is one suggestion given by our Manoj Chatterjee with his own experience. For keloid, their suggestion is combination treatment is best. Combination, you can go for any combination, lesion plus cryo, lesion plus, so they have given the science. But the summary one is that when you are going for IL, think for vasovagal, be precaution, take precaution. And what are the things, again more, so for ear lobule, you can do surgery plus IL, you can do, but chest, no, you should not do it. Last of all, I like to ask our president, Professor Shahidullah, Professor Shahidullah.
Yes.
To end up all, so I'll now, so please see our doctors and staffs who are with us. They work hard to organize this very nicely. Our OT staff, our junior doctors, they work hard to make this program successful. Thanks to you all here. I must thanks to the participants also. Without you, the program will not be successful. So you enrolled your name to get some experience, to get the knowledge. So in our skill center, these are the staff who are with us, and the Uniderma, they assist with us, and the pro system is work on with us. So thank you very much on behalf of me. Now, Professor Shaidullah sir will give you the, as a president, will conclude the workshop now. Professor Shaidullah.
Thank you, Arlo sir. Today I am very happy to witness this sort of workshop. I have expressed earlier in a different session that this arena of Corona has limited our movements but could not stop us. This is why we have started webinar workshop with dermatosurgery. I think in future this sort of webinar will be deleted and the workshop on dermatosurgery will be in practical. Will be all benefited. Today I must thank my dear friend Dr. Manoj Chatterjee. Yes, he didn't miss any of our academic sessions in the past also. Thank you very much, Dr. Manoj Chatterjee. In future, we will also find you in our sessions. And I must thank the presenters today. They nicely presented and demonstrated the procedures. That is very good. Thank you very much. And I must thank the organizers, particularly the Uniderma, photographers, the OT staffs, hands, and lastly, for the young dermatologist participants, I have an appeal to the young dermatologists and also the concerned persons that please, whenever you start this dermatosurgery, take the consent form in written. This is required because Dr. Manoj has already mentioned that is a esophageal attack. There is chance of emergency is there. There is chance of is there. Chance of pigmentation is there. So, before starting our procedure, and keeping in mind the complications and the prognosis, we'll select the cases, and from today onward, you will start this dermatosurgery which have been demonstrated. If you try, you will learn by mistakes. So don't be scared of this bad prognosis or the complications. You start with this thing. If you can successfully complete any of the dermatosurgery shown today, it is the success of our webinar workshop, today's webinar workshop. There are a lot of limitations we have. So your suggestion will give us a full-fledged dermatosurgery workshop in future, and we hope you will enjoy in future more developed, more successful procedures, more successful workshops, both theory and practical, and which will help to develop our dermatosurgery. Thank you very much for your patient sharing. Thank you very much for your presence. Assalamu alaikum.
Writing medicine is a pleasure. Diagnose and writing medicine. But when you do the procedure, it is a great pleasure. After having the result, the smile by the procedure who done it and the patient. So now dermatology is full of procedure with the treatment. Don't think the dermatologists are now doing very good jobs. So last of all, after president's speech, nothing is left. So, but I just like to ask Unimed UniHealth, Mr. Anisur Rahman, will say some highlights. It is our pleasure. He will be with us and the next also. Now, Mohammad Anisur Rahman, Marketing Manager, will say some words regarding their participants.
Assalamu alaikum. Honorable President of Association of Cutaneous Surgeon of Bangladesh, today's speaker, learned doctors, learned audience, my dear colleagues, Assalamu alaikum and good afternoon. I'm Mohammad Anisur Rahman. I'm working as a marketing manager at Uniderma. You know, Uniderma is a concern of Unimed and Unimed UniHealth Pharmaceuticals Limited. I'd like to thank to Association of Cutaneous Surgeon of Bangladesh for choosing us, Uniderma, as the scientific partner of today's first virtual workshop on dermatosurgery. I'd like to especially thank to Professor Afzalul Karim sir for hosting the program, Dr. Mahbub Shahin sir, Professor Asifuzzaman sir, Dr. Rahmatullah Siddiqui sir, Professor Muhammad Shahidullah sir, Dr. S.M. Boktiar Kamal, Dr. Tawhidul Islam Emdad, and from India, Dr. Manoj Chatterjee. And you know, Uniderma is always with the learning procedures. We'd like to continue our endeavor with you, with Association of Cutaneous Surgeon of Bangladesh in the near future, I hope. And I'd like to thank my dear colleagues for arranging such type of, actually supporting the such type of nice program for us. And I'd like to thank all the learned doctors for allowing us to be with you, and we hope we will be with you in the near future. Thank you, sir. Thank you very much. Assalamu alaikum.
So now the time to go. So thanks to you all. Wish you happiness. Take care of yourself. Still COVID is there. Don't worry. We will be happy. Thank you. Bye.
Assalamu alaikum. Sir,